Hello, good afternoon, good morning, good evening, wherever you are in the world. Hope you managed to have a nice break. We're welcome to the session, Broader Determinants of Health, Data from Diverse Sources, which I'm delighted to be chairing. For those of you who have just joined, my name is Cheryl Battersby, and I have a dual role. I'm a consultant neonatologist in London, and I look after sick or preterm babies, and I see firsthand how a child's early life, environment, education, and social experiences influence their long-term health and well-being. This is what drives and inspires my role as a researcher. So in my NIHR Advanced Fellowship, I'm focusing on NeoWonder, which is a program of research that links together health and educational data sets to improve the longer-term health and well-being of babies born preterm. So I believe if we are really to harness data to benefit global health and society, which is the theme of this conference, we need to really look beyond conventionally used health data. So in this session, you'll be hearing from 4 eminent speakers who will bring their wealth of experience and also lived experience on their perspectives on diverse data sources, cross-sectoral linkage of data, but also to address the potential challenges and solutions and how we can work together to ensure that we can better use these data to benefit patients and the public. So really excited to introduce our speakers. Now, you'll find their very full and extensive and impressive biography on the platform. It's far too long for me to go through it all, but in the interest of time, I'll give you a very brief introduction. So we're joined by Tim Chico, who is a professor of cardiovascular medicine at Sheffield University, and he is actually the personal monitoring data thematic lead at the British Heart Foundation. And he'll be giving his perspectives on wearable data and other diverse data sources. We also have Emma Gordon, who's the Director of Administrative Data Research for UK and England, who brings to her a vast experience using administrative data to support research, but also, very importantly, policy making. We're also joined by Rob Aldridge, who is a Professor of Public Health Data Science at University College London, and he has expertise using complex health data and digital interventions. More recently, he's been focusing on the coronavirus in the Virus Watch study. We also have very delighted to introduce Lisa Juniper, who is a parent of a preterm baby, and I've been very privileged to hear her story over the years. She's a collaborator for the NeoWonder program, which we co-lead with the Parent Advisory Group to bring together diverse data sources to benefit our babies and their families. So this is a really interactive format. They'll be giving a short presentation each, but really, we want to focus on that really rich discussion that we want to bring you all into. So please do post your thoughts, your comments and your questions in the chat. You can also like them as well and let me know what you really want to ask the panel. So without further ado, I'm going to invite Tim Chico to give his perspectives on diverse data sources. Over to you, Tim.
Thanks so much. Thank you for the invitation to talk and join the panel. So, Health Data Research UK has made huge progress in finding, accessing and analysing healthcare data. And this has already led to many impressive successes, and we've heard about some of those. So why should we navigate towards other types of data? As a hospital doctor, I had to face up to an uncomfortable truth, and that truth is that the traditional healthcare data I have access to captures much less than half of the factors that influence population and individual health. Behavior, social data, environmental factors collectively are more important than the data we have access to already, but they're far less well represented in the data that we have access to. Now, for me, the definition of health data is pretty straightforward. All data is health data. All data has the potential to reflect individual and population health. This does not mean that we can or indeed should access every single type of data, far from it, in my view, but we should start discussing what additional types of data are available, are appropriate, and are acceptable. So I'm going to start with some thought experiments to give you some examples of data that we know already exists, but we don't currently use in healthcare. And I'd like you to consider 2 questions. Would you allow access to this data for research? And ultimately, would you allow its use in your own direct healthcare? So, as Cheryl says, I'm Associate Director in the British Heart Foundation Data Science Centre, and I lead on personal monitoring, which effectively means smartphones and wearables. Now, as everyone here knows, they are already collecting huge amounts of data relevant to health, for example, on sleep, activity, mobility, heart rate, and the list goes on and on. So would you allow access to this data, and crucially, for it to be linked to your healthcare data in order to make sense of all this? What about if it includes your location, which most of these devices do collect? And what would be the implications of that? Would you like to know how long you're going to live? Well, actually, one of the best ways to do that is a cardiopulmonary exercise test. And you can do that for free in a local park by walking or running 5 kilometers in events run every week by this, in my view, fantastic organization. 2.7 million people have completed this over 47 million times, Andrew Morris amongst them. Should we be using this data? And if we did, who would we be excluding? Every week, there's another confusing diet story in the newspapers. And in my career, coffee's gone from bad to good to bad to just last week, it's good again, which to me is a huge personal relief. You know, retailers increasingly know exactly what our households buy and presumably consume. And would you allow access to that data? And what would be the risks? So, although the data from smartphones and wearables I've talked about focuses on what we do in real life, increasingly our digital life will inevitably influence and reflect our health. Would you share your social media use? Would you share your internet search history data? The risks and potential harms of this approach are far from theoretical. At the moment, arguably, there are more tangible examples of harms, Cambridge Analytica, etc., than there are actually benefits. And this is something we really need to address head on. So since all data is health data, we need to prepare the ground thoroughly, we need to tread upon it carefully, and we need to walk in a direction that we all agree is the correct one. And that's why I'm really looking forward to your thoughts and views and questions in the session. Thank you very much.
Thank you very much, Tim. I'm glad coffee's also back to good. I certainly am guilty of drinking too much. I want to invite Emma to speak next, please. Emma, over to you.
Thanks very much. And yeah, welcome everybody. My name's Emma Gordon, and as Cheryl said, I'm the director of the Administrative Data Research UK programme at the Economic and Social Research Council. So we're a partnership of government and academic groups across all 4 UK nations that are led by my team within ESRC. And we create linked research data sets from administrative sources, making these available to researchers through our network of trusted research environments. And we also fund research to meet government priorities for evidence. And if I go on to the next slide, there we go. This graphic illustrates our achievements to date since we started this programme in 2018. And we've now facilitated thousands of researchers to be able to access linked administrative data for research, working with Whitehall departments and the devolved nations to do this. And just to go back a bit to explain what we mean by administrative data. So this is information collected by systems across civil and public services. So although not collected for research purposes, it can be extremely valuable if used in this way because it has such broad coverage of the population. ADI UK has worked with data owners across the UK to create these linked data sets across all of these themes and making them routinely accessible for research in the public good. And when I talk about health data in this context, just building on what Tim just spoke about just now, I'm talking about all data that can tell us something about the health of a person. So this is not just information recorded by the NHS, either in a hospital or a GP surgery or another setting, about the conditions a person might be diagnosed with or the symptoms they may have. I'm also talking here about data collected, for example, at birth registration, that's not technically classified as health data. And this obviously tells us where and when a birth occurred. It also tells us about the weight of the baby and many other things. There's also useful information collected at death registration, such as the diseases or conditions that led to a death. And finally, there's also a lot of data collected by national surveys about health, such as whether a person has conditions that limit their daily lives. And that kind of information was collected in the 2021 census, if you remember. So this slide illustrates our model for how we work with data owners. And this is all structured around investing the time and effort in creating a linked data set once that we know will be useful to researchers and policymakers, agreeing the government's processes up front that should sit around it, then making it accessible to the research community through a trusted research environment. So that's portal access to the data. The data is not given out directly to researchers within their organisations. I should stress that data shared with researchers via ADI UK is de-identified, and this means that names, addresses and any personal IDs are all stripped out before the researcher gets access to it. And there are also rigorous safeguards in place to protect it from re-identification. So in the context of what Tim was talking about, where he was talking about data linkage for direct healthcare use, this is not that. This is only for research use on the population. All projects as well must pass the public good test. So from public dialogues and public engagement work that we've done, we know the public are broadly supportive of this data being used in this way. And this is a constant thing that we check in on with every single data linkage programme we run and every project that we fund. An example of this type of data linkage that we've been able to make routinely available to researchers is something like the COVID infection survey data that ONS collect. And this is the data set, the survey from which the weekly estimates of COVID prevalence across the UK have been calculated throughout the pandemic. And this has been linked to death registration data. And through this, researchers have been able to calculate the differences in not just the health status of people vaccinated or unvaccinated, but also the death rates associated with different variants of COVID. So incredibly valuable research that can tell us a lot about the health of the population. And just to tie this back to the title of this session, which is Broader Determinants of Health and Data from Diverse Sources, my pitch to you today is that there is so much more research that we could facilitate if NHS health data was covered by the Digital Economy Act. And this is a permissive legal gateway that we use to gain research access to all of this government administrative data. So it's very well understood, as Tim mentioned, that good or bad health is not simply the result of individual behaviours, genetics and medical care. A substantial part of the difference in health outcomes is down to the social, economic and environmental factors that shape people's lives. And this is just some of the reports and some of the organisations that we're working with that have and are highlighting this. So if there were systematic ways to open up access to linked, de-identified NHS health and administrative data, then we could conduct population-level research on links between, for example, social inequalities and differences in health outcomes. And in turn, this could inform government policy to tackle seemingly intractable health-related problems, which impact both individuals and their families, but also the economy more widely through lost earnings. And we're currently having incredible data sets that fall into this category, such as a linked data set we've got called eChild. And this links over 20 years of health and education data for England. And this linkage was done so that researchers could track how groups of children with severe health conditions have had their education impaired by the pandemic, and how their catch-up is faring compared to that of their peers. But frustratingly, currently we can only make it available to one research group, that the group that were funded to create it initially. But there's so much more research that could be facilitated if we were able to open up access to researchers more widely. The problem is, at present, there isn't a straightforward legal gateway to facilitating access to linked, de-identified NHS health and administrative data. So a lot of research that could be done to properly understand the wider determinants of health is just not happening. And this could be changed, for example, if NHS health data was covered by the permissive research powers in the Digital Economy Act. Thank you.
Thank you, Emma. That's really nicely following, and Tim's really focused on the diverse data sources, and I'm really looking forward to picking up on some of the points you've just spoke about. Without further ado, I'm going to introduce you and welcome Rob to give him his perspectives, please.
Thanks very much for that really interesting talk so far. What I'd like to do now is really talk about the use of diverse data sources to understand and improve wider determinants of health. And in my thinking around that, within my research, have been using a particular transdisciplinary model. I don't know if we could just forward the slide, please, so that the model is on the screen. Thanks. So this model is a conceptual framework that was created by Dr. Helen Pinio at the UCL University College London. And I think it's a really useful way of thinking about what I was asked to talk about in terms of barriers and enablers for accessing these wider determinants and diverse data sources. Because really, when we're going and using data sources from diverse situations, and from, for example, the Tesco Club card data, the geolocation data that Tim mentioned earlier, we need to involve quite a range of people. And by that, I mean people from different scientific backgrounds and disciplines, because if me as a public health researcher is analysing geolocation data, I need to involve people with the right sort of skills. But then also, really importantly, we need to understand the perspective of people whose data that is, how it's being collected and how we're using it, and what they think it can be used for. So we need to engage with experts by experience. But also, I'm very focused and wanting to make a difference. And to be able to do that, one of the key audiences for the outputs of the research are policymakers. So involving policymakers in the design and implementation of research projects means that they get the actionable evidence that they're able to use at the end of a project. And this transdisciplinary model is really helpful in terms of being able to think through that. So it's got 6 boxes. And the co-learning box at the top of this model really is around about thinking and understanding the fact that not everyone that's coming to a project with a diverse data source will understand what the data look like, what is within that data, how to use that data. So to pick an example from the VirusWatch study that was mentioned that I've been leading, the geolocation data that we collected from over 2,000 participants gave us records on over 170 billion GPS data points within the participants over the course of the second lockdown. And we wanted to use that to understand whether people were changing their behavior as a result of policy changes. But we weren't able to really do that without the help of geoinformaticians here at UCL, and also the company that helped us design and use the app at Esri. So that co-learning phase that we went through as academic researchers who were gathering the data and bringing it into our secure research environment really required us to co-learn with those individuals and understand what were the appropriate ways to analyze that data. And it's a continuous process that you need to, in particularly when you're using diverse data sources, goes throughout the life of the project. The reflection and the refinement box at the bottom of this model is also really important, because what I've found, and I think what often happens in projects where diverse data sources are being used, that you do learn along the way, and you do have to kind of readjust the ways that you're analysing the research questions that you're analysing. And I think COVID again was a really important example of that. That throughout the last 2 years, we've continuously reflected upon what is it that we're trying to achieve, what is it that's most useful for us to use the data for, what do we need to do to kind of have the biggest impact and make a difference at that time. So I think whilst it's still super important to have a priori research questions and have a really clear protocol for research and the design of research and the use of that data, not least because you need it to get the legal permissions for undertaking that, I think it's important to understand that reflection and refinement needs to go throughout, particularly in studies where you're using diverse data. The pre-development phase I won't talk too much about, but that is really about getting the right legal permissions for that data set. And I'm particularly interested to hear that it might be possible to share health data more widely if it fell under the Digital Economy Act, because that's something that we've fallen into a trap for, and I'd be really encouraging of that to happen, because I think we've not been able to share data, and I've not been able to make data more widely available once we've linked it to health service records. I think it's a real travesty. So in particular, we did a project where we linked the records for people experiencing homelessness, showed some really important outcomes that could have been very used much more widely. But at the end of the project, we had to destroy that data because of the fact that we weren't able to share it more widely. And it was extremely disappointing to be able to do that, to have to do that. The conceptualization phase, I think, is important. And I don't think, particularly as data scientists, and I'm guilty of this, we think enough about. So in this phase in particular, it's thinking around the theoretical frameworks of how diverse data are relevant and the most appropriate methods, the most appropriate ways of conceptualizing that data. They're really important to consider, because actually it's important to know that when you're using the data that isn't necessarily from your primary discipline, you are not necessarily going to have the right conceptual framework to be able to do that. And so it's important to explicitly think through those issues. And if I consider one topic in particular that's becoming important for epidemiological designs, is thinking through, if your research question is causal, thinking through in advance what your directed acyclic graph, your DAG, looks like for your analysis, so that you're explicitly defining the causal mechanisms that you're considering from within your research, so that your analysis, when you get to the next investigation stage, is appropriately thinking through it, is appropriately modeling those data. And then finally, the investigation box, I'm not really, again, going to talk too much about, because this is the kind of bread and butter of what we're doing in research, and there isn't really too much need to add to that from this model in particular. But the final box, implementation box, whilst it comes here at the end here, I think one thing I just reflect upon is the fact that by involving experts by experience, by involving policy makers throughout the process, and by involving researchers from different disciplines, you're going to end up with a research product and an evidence that is much more implementable and much more actionable at the end. And so I think this box does come at the end, and it's the last bit, but you're thinking about this all throughout. And just to highlight highlight some important issues here, I think we've learned throughout the COVID pandemic how important it has been to really engage with experts by experience and policymakers. So we've learned that by setting up a steering group for the Virus Watch project, we were able to reflect and identify research questions that we weren't thinking about by discussing those with our people, our champions in the community. So, for example, we looked at disability, the intersectional relationships between disability and ethnicity, because this was something that they felt wasn't being looked at, and we as researchers wouldn't have thought about that. But actually, it's been really important to generate and implement surveys for that and reflect those priorities of people and members of the public, and then give that evidence to policymakers so that they can then fill the gap and take action from that. And equally, by working with UK Health Security Agency and government agencies throughout, we've been able to understand what their priorities were, so that we could do surveys within the Virus Watch study that identified and filled gaps in the evidence that was missing and they needed data for, and also equally not carry out surveys that they already had lots of data for. So one example of that was that when we set out with Virus Watch back in the beginning of June 2020, we envisaged the fact that we would be doing weekly incidence estimates, but it became really obvious that with the ONS infection study, that was not something that we were going to add value on. So we changed the study to reflect that issue and move towards more detailed socioeconomic determinants of health. I'm going to stop there, but hopefully that's given some idea about thinking through what the barriers and the enablers might be to diverse data sources. Thank you very much.
Thank you, Rob. And yeah, really important, as you've highlighted, to involve research from different disciplines and also policymakers. And importantly, as Tim's also pointed out in the beginning, really important to involve the public in these discussions. And that's why I'm just so delighted to introduce Lisa, who's a parent of a preterm baby, who's been a real advocate of using data that already exist but need to be linked together. So over to you, Lisa.
Thank you, Cheryl. I'm so pleased to be here today, and I'm really, really grateful to have this opportunity to speak to everybody about my experience from having a preterm baby and how I ended up here today. Before Theo was born, I was a nurse and I knew about research. Obviously, we do evidence-based practice in everything that we do. We strive to do that. And Theo was born at 25 weeks, and from that day, my life changed completely. As Ken mentioned earlier in the keynote speech, you can have an idea of what the world is and what your world involves. And on the day that Theo was born, my world completely changed and a whole new world opened up. So you can have an idea of what it might be like to have a baby born early. As Cheryl would say, I've worked with her quite closely for a while now, and as a consultant working in the units every day, there's things that by working with members of the public and people with lived experience, even that she didn't understand from being in that environment herself. So Theo was born at 25 weeks gestation, at a crucial time for brain development. The whole of his third trimester was spent in an incubator like the one in the picture. Every single system within his body was supported mechanically or by medication to help it work. And that is so far removed from the experience of what it would be like in the womb. So his brain and all the neural pathways and nothing is being developed in the way that it should be. So this is Theo now. So we spent 123 days in the unit, and when you're in there, you realise that a lot of the medication that's given is given off licence. A lot of the research that is around prematurity is done within the first year of life. And then when you get home, it seems to stop a little bit. So there's no real knowledge or understanding. So the professionals, the health visitors, when you go to clinics, you discharge from your consultant when you're 2 years old as a preterm baby. And then when you go to school, very quickly, you realise that actually they're not at the same level as the peers, and there are gaps in things. So from our point of view, Theo can walk, he can talk. He does have a lot of ongoing needs of prematurity, but it's the social and emotional understanding. It's those foundations that of attachment and not experiencing painful procedures every day. It's the impact of adverse childhood experiences that there is literature for, but a lot of it is around children that have experienced abuse and neglect and things like that. So there's not really much evidence as to what happens in the long term after you've been born prematurely. So for me, I thought I can't be the only person in the world that thinks this. So I quickly got involved with our parent advisory group in the Northwest where I'm based, and I realised that so many people are experiencing the same challenges as us. So if we are working on evidence-based practice, but there's no evidence for the follow-up, how, we're told a lot of the time, oh, they'll catch up, or, oh, aren't they doing really well, compared to this child or compared to this child. It's like a horrible lottery that you wouldn't ever want to be involved in or part of, but you are. So challenges for us is Theo's deaf. He had grade 2 to 3 intraventricular hemorrhages in his brain bilaterally. So that means that now he's got periventricular leukomalacia, which can cause cerebral palsy and things. So he's long-sighted, so he wears glasses, and he has chronic lung disease of prematurity. He's got low core muscle strength, so he struggles with things like being able to balance on the beams that his friends can do at school, being able to play football like his friends can do at school, and things that now is starting to psychologically have an impact on why can my friends do this and I can't. So as part of the work that I've been doing to try and speak to anybody and everyone who will listen, is to be part of focus groups, get involved with research, and try and raise the profile and raise awareness of why it's so important to have this information out there. So I met Cheryl through the Neo Wonder study that she's founded, and I started off by being involved in the focus groups, and we spoke to parents. Cheryl said that she wanted to link the data of from neonatology to child health to social and ongoing. And I probably naively thought, why is this already not a thing? Why is this already not happening? And then in the little impact and involvement that I've had in it, I've realised why it's not, because of all the stress and the headaches that Cheryl's had to try and put it all together. So but as part of this, a questionnaire was sent out to parents, because a lot of this talking about today has been around consent. So if we're linking the data, which is an opt-out thing, so it's just assumed that consent is there, in order to understand more broadly about what parents and public think about that, a questionnaire was sent out, and the large majority of people agreed that actually it is necessary, because I think when you've been through a life-changing experience that impacts on you and your family and your son and their future going forward, it's not about consent, it's more the clarification about how your data is going to be used, whether it's safe. What Cheryl and her team did when they had the results of the questionnaires was they interviewed, they did some detailed interviews with some of those people, and some of the concerns that came up were whether the data would be sold or what would happen to it, whether it could be related back to the person themselves. But once those queries had been had a conversation with the public, then it quite clearly was evident that it's necessary and it's important, and it's what needs to happen. So on the website, there is a video that shows how the data is going to be linked, and there's a website there with everything that's happened so far, all of our profiles, and how you can get involved even further. Cheryl will be able to answer any questions, obviously, that are more technical. I've just been involved with the parent part of it. But like I said, quite naively, the data is already there, the information is already there, and because it's not ethical to do randomized controlled trials on babies that are receiving life-saving treatment, there's obviously implications with that. So the only other way that we're going to get that information is by accessing the data that is already there, linking it all together, and seeing what investigations and things that happen influence the outcomes of the children. So that's me. I'm going to stop there. Like I said, it has been a life-changing journey for me. I'm very grateful to have the opportunity to speak, and I'm very grateful for people like Cheryl that are working hard to try and change and influence and make the long-term outcomes for babies and children born early better. Thank you.
Thank you very much, Lisa. It's always a privilege hearing your story and your perspectives. So we're going to thank you very much to everyone who's put comments and questions in the chat. I'm going to try and bring those themes through, and when we have our panels all together again. So I'm just going to pick up on one of the themes that relate to your talk, Lisa. So when we did go out and speak to parents, there were differing opinions because some of them didn't really appreciate or understand, how we would use the data, who would access it. And I'm just going to pick up on a point that one of the attendees have raised about, could there be different perspectives from those who have lived experience, such as yourself, and others who may not really come to benefit as much from their data being used? How do we try and begin to explore those perceptions?
Yeah, that's what I found as well. So when we're hearing about the data, from your Tesco shopping or things that have been brought up, it is very different. So this data that from the prematurity and from the families and the children, it is necessary. And I think the throughout across the board, the most important thing is to have transparency in order to build trust. So involving people, as everybody has said, parents and the public, experts by experience, but also in generally, if there's any doubt in the ability to be able to trust, the use of the data, then people are not going to go along with it. It obviously you are more inclined to do so if it directly benefits you or your family, or you are passionate about the reasons behind it. But otherwise, it just has to be absolute clarity and transparency in order to build that trust.
And I guess the question perhaps for yourself or Tim or Emma is how do we reach out to the public to engage them and share the information we have to bring that transparency? Because I think everyone's busy. It's hard to reach all parts of the society, and we want to make sure there's inclusivity and diversity. How do we do that on a larger scale?
I can talk a little bit about that, actually, Cheryl. This summer, ADI UK and the Office for Statistics Regulation did a major public dialogue project that was right across the UK. We went out to all four corners of the UK and sort of followed up with people who couldn't attend in person and did an online session as well. But this was all, and the people that were involved in this public dialogue from the public side, we intentionally reached out to people who had no awareness of research or training on the use of data, that it was not their world. And we went out to test the ADI UK model of opening up access to de-identified data in trusted research environments, and to test where the lines were that we really shouldn't cross, but also where we should go further, where we should embed more public engagement into our decision making. And it was an incredible sort of piece of research, and I'll post the link to the report in the chat. But fundamentally, there was broad support, which has given us a kind of real confidence boost that our approach is a good one. It's trustworthy with the public, and that's incredibly important for us, because we know that we have to go above and beyond what is legally required of us to maintain that social contract to use this data. But as I say, it's also challenges in quite a few ways, and it's come up with a set of recommendations that they've put to us and the Office for Statistics Regulation about where we should embed it more. So it's through processes like that, there are mechanisms and they are effective.
Thank you, Emma. It's great to hear that public dialogue, and clearly, yes, we all have a duty to continue that momentum and changing mindsets as well, and having the public behind us in supporting use of these data. I'm going to pose a question now back to Lisa, and I think this is a question that often comes up in any drug development or working with industry. is, do we have any red lines, or do the public have any red lines about, using these data to perhaps benefit, for example, industry that might make a profit?
I'm not sure. So with regards to research within the neonatal unit, I think I've said to you before, Cheryl, because of the experience, like the incidence of post-traumatic stress disorder of parents that experience neonatal care is huge. So when you're making those decisions about research studies that might be going on within the neonatal unit, that's very much driven by emotion and the trauma that you're experiencing right there and then. With the same thing in mind, when you leave and you're going through those struggles and you're thinking, how and why are the services not commissioned? How and why do people not understand what we're experiencing as a family that so many people are experiencing? By that, you're more driven to say yes, like do anything, whatever you have to do, please. So I'm not sure about how I would feel about people benefiting from it, but if they were the only people that were to provide the answers for what the questions that we really desperately need, then I would do whatever it takes. But like you said earlier, not having that vested interest and need for it, I'm not sure it would be so widely, thought of in that respect.
Thank you, Lisa. And I think, it's been picked up in the conference so far, is that mutual benefit, isn't it? And maybe, making sure that the public will benefit from that partnership with industry, such as we've seen with the COVID vaccine developments. And I think, that is a real good case study for that. I'm going to just change a bit of a conversation, because there's a lot of mention about the Digital Economy Act, Emma, in the chat. And I think you've sort of taken the words out of my mouth, and that frustration of being that accessibility to data. And I know about the eChild, and we were hoping to access those data to reduce research waste, to be honest, so we don't have to be duplicating. And there were mentioned in the chat about, collecting data once, linking once, and then using it for multiple purposes by different researchers and policymakers. How do we overcome that? And there's a little question about how that is in Scotland as well.
Yeah, it's a really interesting one. And what you're talking about in the health space, that's exactly how the administrative data research space was before the Digital Economy Act was passed. So this is permissive legislation to allow research access to de-identified data in very, very controlled circumstances. So it's all through these trusted research environments. It's not sending the data directly out to researchers, and it all has to be done in the public good. So there's a lot of checks and balances that are really leaning towards making sure that we maintain that social contract to use the data. Unfortunately, and I entirely understand the reasons why, health was specifically excluded from this act, and it was because of the appetite of MPs just wasn't there to reopen the debate about accessing health data for research. Because if you remember back, those with long memories, the care.data scandal of 2010, MPs were still so scarred from that all going horribly wrong. And in my opinion, that all happened because the government forgot to discuss with the public, is this kind of data access, what they were proposing, is it acceptable, is it not, where should we draw the line? They just came out with their view of how it should all work. We've all learned from that. But the Digital Economy Act is UK-wide, so it's in use right across all four corners of the UK to open up access to administrative data. If health data could be made the Digital Economy Act updated, it would make that data available on the same grounds. And the really nice thing in terms of maintaining public trust about that act is the fact that it's only giving de-identified data accessible, making it available to research, because although there's multiple hoops to gain access to health data, and it's different in all four nations of the UK, if you do get access, it's almost like there's no grayness in the spectrum between you either get a no you can't or a yes you can, and here is all the personal identifiers too. This middle ground of maintaining, that helps maintain a lot of the security around the data and the public trust, could be overcome if the Digital Economy Act was updated to include health.
Okay, thanks. And Rob, you mentioned that may help in your work as well. Did you want to comment on the challenges you face?
Yeah, there's been a couple of studies that I've been involved in where we spent several years, for example, collecting data on people who are experiencing homelessness, who were admitted to hospital. We worked with services that were helping those individuals during their hospital admission, and we collected using legislation that enabled us to collect that data without consent, Section 251. We were able to then link using that legal basis to the subsequent hospital records of those people and show some really important information. So, for example, that if appropriate and timely healthcare had been provided to these individuals during that hospital admission, we could have prevented 1 in 3 subsequent deaths that we saw. And that data set would have been an enormously useful product and data source for other researchers to be able to use to design better services for this group. But because the permissions that we had were not under the Digital Economy Act, we had to destroy the data at the end of the project. And it was an extremely frustrating process to go through because of the public benefit that there clearly was within that data and the amount of time and effort that we'd gone to collect it. So I think that if we can change the Digital Economy Act to include that sort of information, so to include health data, I think there'd be enormous additional benefits from that.
Thanks, Rob. I'm going to bring in Tim now here, because there's a lot of interest in the chat about your using, out of the box or bit of off-piece data, I would say, which clearly are a real opportunity. And I guess, how does the legal framework and all the governance, influence the use of the data that you want to use, for example, from park runs? And there was some chat about Tesco Club Cuppers also in a previous talk about using credit card details and where you shop, etc. I mean, how are we going to overcome those barriers if we really want to use those data?
Well, I mean, there's 2 legal bases for any of this work. One is the without consent and the Section 251 approval that Rob's just talked about, but then the other is actually getting the consent of the participants. And actually, that clearly has to be the way that we would initially start to get around this. But of course, we would then also need to recognise it will kind of be the usual suspects who sign up and give consent, and it will perpetuate the difficulty of knowing that the data is representative and diverse. I guess just to generate a bit of artificial conflict in the panel, I'm not sure we've completely learned from care.data, because we wouldn't have had GDPR more recently, and I think we need to get a lot more proactive and frankly a lot better in our communications with the public, recognizing that although Andrew Morris has already said, and I agree, that papers are the currency in our world, they mean nothing to the public. What matters to the public is value and impact. And the reason people still use Facebook, despite the fact they know their data is being used for lots of different reasons, is they have a value from using Facebook. We kind of come at them with these articles of faith that, give us this data around better healthcare, we'll come at you down the line, details to be disclosed. And that's not a very compelling narrative. We need to, as quickly as possible, use, the representatives of people like Lisa and other colleagues to first of all explain the need. There's an absolute urgent pressing, right now, we need better healthcare for these reasons. And then as rapidly as possible say, and this is how the data has led to addressing those needs, without kind of seeing research as the good in itself, because unless it leads to impact, then it's not going to convince the public.
Lisa, you have your hand up. Oh, you're muted.
Sorry, thanks. I was just going to add on to what Tim and Rob have both said about the using the public can really it's real life experience. So it's what the need is, where are the gaps, and what can we do to help. So I know from working with you that it's not just about public participation in the research itself that's important. It's the co-design. It's right from the beginning. How can members of the public, experts by experience, and just in general be involved from even before the design? What's important, what do we need, and then through to the design. I've been to ethics meetings for, to get approval and things like that. There's no part of the research that can't have public involvement, and that's really important, and that's where you get your transparency from as well. Just being completely open. This is what it is, this is what we need, but also then that's mutual learning and understanding as well, and that's another way.
Thank you, Lisa. I've certainly benefited from your presence in my ethic meetings, and I cannot recommend highly enough to involve them at each stage of the research cycle. And I just wanted to pick on a point made and a question in the chat, quite a few actually, to ensure we have diversity and inclusivity as well. Just thinking about those populations which might be a little less represented, as you spoke about, Tim. That there's certain populations that wear wearables, certain that have technology. Yes, we're not making any assumptions, but how do we ensure that our data have diversity and inclusivity to make them generalizable in our findings?
Well, if I could take that one, we need to give people the devices if they don't have the devices, and not just the devices, but they need the data infrastructure and they need the training, and then the devices need to have the interfaces accessible for people that have, different languages, different kind of skin tones, different abilities to manipulate small buttons on devices. So that's easy. It just needs a bit more money in the program of work, and that's fine, because these devices cost a lot less than coming to see me in clinic, and potentially more useful in the longer run. So that would be my suggestion.
And in terms of sustainability, going that concept of, there's two aspects to it. The one is that linkage of data and that technical infrastructure that we need for these very large data sets going forwards, but also that continual engagement with the public. How do we ensure this sort of blueprint going forwards is sustainable? Is it talking to policymakers? Is it banging on politicians' doors? Is it?
If I think the key thing is show value as quickly as possible, so it can be incorporated within routine healthcare, because then routine healthcare is footing the bill of collecting data, and because it's routine healthcare, it's in the most diverse and representative population, just like the NHS is. That's why it's so useful to do data on non-consented participants, because it is a lot more representative. And I think that's why we need some pioneer projects that allow this data to be collected in routine healthcare, show their value, and then that will rapidly accumulate a very large representative data set which we can expand upon.
Thanks. And I like that concept of reframing what health data are, Tim. So you say all data are health data, and there's a nice comment here that why do we regard health data so special? Its health is determined by environment, genetics, infection, etc. So do we need to be changing our mindset and reframing? Emma.
Yeah, just coming on this, because it is a really important issue, actually, because if you ask the public, about, is it okay if we link this data with this data, they see it as a no-brainer that health data should be considered alongside all other forms of data. Because you think about those children in the eChild, represented in the eChild data set, if they can't access education because of their health condition, those things are two things that are inextricably linked in their world. And of course they're not separate. And it's only because they're separated in legal terms that you end up with these very, very different systems for the decision making around accessing it. And if we could bring equality to that, then the rest will flow, I think.
So it sounds like, Emma, that legal framework is incredibly at the centre of this all. And it sounds like ADR UK are, making some positive steps. Is that correct?
Absolutely. And we're working really, really constructively with NHS Digital and DHSC on this as well. They're absolutely supporting us. Obviously, everyone in this space wants to keep the right side of the law. We have to, if the law is not fit for purpose in this sense, then how do we update the law? And obviously that's a sort of a long process, and it's not straightforward, and it shouldn't be, but it is for the greater good at the end of the day. So yes, absolutely, we're working with them on it.
Thanks, Emma. And just for the final few minutes, I'm just going to try and begin to draw this to a close, because I think we've just discussed some really, the enablers and the barriers to this. But what's really coming out in your themes is that we do need to show impact to be able to influence your policymakers, your politicians, and those with the purse strings, and maybe those in their legal powers, to try and change that landscape so that it will make and facilitate the research we want to do, and to bring the diverse data sets together, which seem at the moment slightly bit more challenging than one would like. And a lot of wasted time and resources are going into doing that. So I just wanted to just go around the panel, and can I just ask you, how can we best show impact? I mean, in your experiences, what's really worked, and how have you, what format and what ways of dissemination and what networks should we as a research community be doing more of to really spread that message of how important there are broader determinants of health and other data sets we need to bring together? So can we start? Who else wants to start? Don't mind.
I'm happy to start on that. So in ADR UK, as a programme, we have a policy of dual publication. So alongside the scientific publications, all the researchers that we fund also publish blogs that they're all available on our websites, and data insights about sort of translating the findings of this research into really, really, sort of plain English summaries. And this isn't just so that the public can read about it. There's a big kind of Chinese wall between government departments and civil servants and academics, because if you're only ever publishing things in scientific journals, the chances are those policymakers, they're not going to see that research. So it's a way of us reaching out to the policymakers as well to evidence the findings from this research.
Thank you, Emma. Rob?
Yeah, I think my experience is, as per that transdisciplinary models, you've got to think about it right from the start. You have to get funding to enable you to do this, and you need to involve the people who are going to have the impact, are going to be able to use your data. And that isn't just policymakers, that is community groups, it is people it is experts by experience in the general public. Because if you involve them and enable them to take part in the research and give them the results and the evidence that they want and they want to be able to use, they will become the change makers for your research and your outputs.
Thank you, Rob. Lisa?
Yeah. So there's lots of opportunities to involve the public. So in particular, charities, they're very accessible, and there's lots of charities for various different things. But I think the most important thing to consider is when you're including parents and public and experts by experience and non-experts, is if you're involving them in your research and you want them to contribute effectively, it's include them as a partner, somebody with equal value, with a place at the table, that brings ideas and thoughts and experience and value, the same as anybody else and the next person, because I've truly felt like that, and that's what keeps me going. And that's what's really important, because to feel valued and to feel that your voice is just as important as the next person is a way that people will contribute effectively and feel valued and continue to do so.
Thank you, Lisa. So it's having parent and patient public involvement and engagement, which is not tokenistic, which is truly mutually beneficial and authentic. Thank you very much, Lisa. And I'm going to give the final word to Tim.
I think, I mean, it's hard to follow all the other speakers, but I think we need to think of data as the intervention, like we think of a drug or a medical procedure, and we need to rapidly show that when this data is used, you get greater value, better outcomes than when it is not. And a few narratives like that would take us a long way.
Thank you very much, Tim. That's great. And I'm just going to, I'm just looking at time now. I just want to really finish by thanking all the speakers. And I think we've had a really good discussion about the importance of bringing together diverse data sources, because health is influenced by so many other aspects of our lives. But we need to bring together the public in that conversation, policymakers, and also researchers from a diverse range of backgrounds as well, which I think your work among all of you have really illustrated that, and really putting the patients and the public at the centre. So thank you very much. And to all those who pose questions, it's been a really great discussion. So I'm just going to close this session, and I think you have a break now and return at 3:35 for global health. So we'll see you then. Bye-bye.